Imagine for a second, learner, that you're sitting down in a perfectly quiet, perfectly comfortable room.
Sounds pretty ideal.
Right. The temperature is perfect. The lighting is soft. But suddenly, your body's internal communications system, like the intricate wiring that normally tells you a breeze is cool or a stove is hot, it just starts sending out this constant aggressive static.
Oh, man, yeah.
Or even worse, it starts sending false alarms. So you feel this searing, burning sensation, but there is absolutely no fire anywhere near you.
It's just completely out of nowhere.
Exactly. You feel a sharp, agonizing pain from just, I don't know, the light touch of a cotton blanket. The wiring has just gone completely haywire.
It is, it's a profoundly unsettling experience to have your own senses betray you like that.
I can't even imagine.
Yeah, and what you're describing is a total breakdown in the peripheral nervous system.
Yeah.
And while the clinical term peripheral neuropathy might sound like this highly specific, maybe even niche medical diagnosis.
Yeah, it sounds super tech.
Right, but it actually provides this fascinating window into how our bodies keep us connected to the physical world around us. It shows us the invisible infrastructure of our daily reality. And, crucially, the absolute chaos that ensues when that vital connection breaks down.
Okay, well, let's unpack this because that is exactly our mission for this deep dive.
Let's do it.
We are looking at a really comprehensive nursing presentation. It's titled Sensory Perceptions, and we're going to look at exactly what happens when the body's wiring short circuits at a microscopic level.
Right.
We'll look at how medical detectives actually track down where that short circuit is happening and the surprisingly complex and honestly sometimes totally mysterious ways we try to fix it.
Well, to really grasp how to fix a malfunctioning system, we first have to understand the normal wiring, right? Like how it sustains damage in the first place.
Makes sense. Where do we start?
So our peripheral nervous system is inextricably linked to our central nervous system, which is basically just the brain and the spinal cord.
Okay.
If we think of the central nervous system as like the main computer server in a massive office building, the peripheral nerves are the miles and miles of cables running out to every single printer, monitor, thermostat, and security sensor in that building.
Okay, let's zoom in on those cables for a second, looking at the actual anatomy of a single neuron.
Sure.
Because the presentation has a great visual. We have the cell body, which acts like the control center, and it has these branch-like structures coming off it.
The dendrites.
Right, the dendrites, and they receive the signals. And you have this long tail called the axon.
Yeah.
And covering that axon is the myelin sheath, which is made up of these things called Schwann cells, with these little tiny gaps in between them.
Yes, the nodes of Ranvier.
Wait, the gaps have their own name.
They do, the nodes of Ranvier. They're actually super important.
Okay, so if the axon is the copper wire carrying the electrical signal, the myelin sheath is like the thick rubber insulation wrapped around it.
That's a perfect analogy.
So when that rubber insulation wears away, the copper wires are exposed and they just start sparking unpredictably.
That holds up perfectly when you look at the mechanics of nerve transmission, because the myelin sheath doesn't just protect the axon, it actually acts to speed up the electrical impulse.
Oh, really?
Yeah, those little gaps you mentioned, the nodes of Ranvier, they allow the electrical signal to essentially jump rapidly down the line rather than, traveling the entire length of the wire slowly.
Oh, wow. So it's like skipping a stone across a pond.
Exactly. So when that myelin insulation is damaged, the signal either drastically slows down, gets entirely misinterpreted by the brain, or just stops altogether.
That sounds disastrous.
It is. And one of the primary ways this devastating damage occurs, particularly in older adults, involves vascular changes.
Vascular, so blood vessels.
Right. We're talking about severe spasms in the blood vessels, or atherosclerosis, which is the narrowing and hardening of the arteries.
Which simply means not enough oxygen-rich blood is making its way down the pipeline into the extremities, right? Like the pipes are clogged.
Precisely. Because nerves are living tissue. They require a constant, robust supply of oxygen to function.
Right. They aren't literal copper wires.
Exactly. When there are insufficient amounts of oxygenated blood circulating to the tissues in the extreme ends of the body, like the legs and feet, the nerves essentially begin to suffocate.
Oh, that's a visceral image.
Yeah, and this inadequate circulation to the muscles and nerves is what results in chronically cold feet, a pervasive, heavy numbness, and this very specific painful symptom called intermittent claudication.
Intermittent claudication. I've actually heard that term. That's the intense cramping pain in the calves, right?
Yeah, it is. It's a severe cramping pain that typically flares up when a person is walking or exercising.
Because the muscles need more oxygen then.
Exactly. The mechanism is straightforward but really painful. The leg muscles are working hard and demanding more oxygen, but the compromised, narrowed blood vessels simply cannot deliver it.
So the nerves are suffocating, and they basically scream out in response.
That's exactly what's happening.
So what does this all mean for how the damage actually unfolds over time? I mean, does this damage always happen gradually, like rust slowly eating away at a pipe over decades? Or can it just happen instantly to one specific wire?
Well, medical professionals categorize this into two distinct types based on exactly that timeline.
Yeah.
The gradual systemic rusting you mentioned usually falls under the umbrella of polyneuropathies.
Poly meaning many.
Right. These are bilateral, meaning they affect both sides of the body equally. So if it's in the left foot, it's in the right foot.
Got it.
They're broad systemic sensory disorders. And the most common driver of polyneuropathy is actually diabetes.
Because of the blood sugar.
Yes. Chronically high blood sugar is incredibly destructive. The excess glucose molecules essentially damage and coat the tiny microblood vessels that supply the nerves, slowly starving them over years.
Wow. And the instant snap, like the sudden damage.
Those are mononeuropathies. Mono, meaning one.
Okay.
This is isolated damage affecting a single specific nerve. The root cause here isn't a systemic whole-body disease, but usually direct physical injury, acute trauma, or repetitive motions that physically crush or damage a localized area.
So if the wiring is failing, whether it's from years of high blood sugar rusting the pipes or a sudden physical trauma, how does that actually feel to the patient?
It's intense.
The presentation breaks the clinical manifestations down into two distinct categories,
Yeah.
right? Sensory nerve damage and motor nerve damage.
That's right.
And on the sensory side, it's just wild. It's not just a generic pain. It's a complete distortion of reality.
It really is.
It's feeling pain from a completely normal light touch. It's an agonizing, burning feeling, intense numbness, and incessant tingling. It even causes profound balance problems, which I didn't expect.
Yeah, the balance issues are a perfect example of how vital this invisible system is. Your peripheral nerves are constantly sending these tiny micro updates to your brain about the exact position of your joints and muscles.
Like GPS coordinates.
Exactly. It's a concept called proprioception. If your feet are numb and those signals aren't reaching the brain, your brain literally doesn't know where the ground is.
That's terrifying.
You completely lose your spatial awareness.
And that sensory miscommunication is only half the picture. Because we also see motor nerve damage.
Right.
The signals coming down from the brain, telling the muscles what to do, they get scrambled on the way out,
Yeah, the outbound signals.
which leads to intense muscle cramping, visible twitching under the skin, and reflex abnormalities where the body's automatic physical responses are either severely delayed or just completely absent.
It's a total breakdown of the system.
So if the body is throwing these wild, fake warning signs like the burning, twitching, cramping, how do you prove it's the nerve failing and not an actual muscle or skin issue?
That's the million-dollar question.
How do medical teams actually find the exact location of the short circuit?
Well, you have to literally measure the electricity.
Wow.
The absolute cornerstone of this diagnostic process is the electromyography and nerve conduction study, widely abbreviated as EMGNCV.
EVGNCV?
Yeah, this is where medical professionals stop guessing and start directly measuring the electrical activity and the speed of the nerve signals.
I have to say, the imagery of this test from the source is fascinating.
It's very hands-on.
You have doctors placing physical electrodes directly onto the patient's skin, say on the hand and wrist.
Right.
And they are physically mapping the pathway of the nerve with a standard tape measure, just to know the exact distance between 2 points.
The literal tape measure, yes.
Yeah. And then they use a handheld device with metal prongs to send actual electrical impulses into the skin to test the nerve's reaction time. They are literally shocking the system to see how fast the signal travels from point A to point B.
It is a brilliant, purely engineering approach applied to human biology.
It really sounds like it.
By knowing the exact distance between the electrodes, thanks to that tape measure, and timing exactly how long it takes the electrical impulse to travel that specific distance, they calculate the precise conduction velocity.
The speed of the signal.
Exactly. The math tells the story. If the velocity is slower than normal, they know the myelin sheath, the insulation is damaged, and the signal is leaking.
Oh, okay.
But if the signal speed is fine, but the electrical impulse itself is weak upon arrival, they know the core axon, the copper wire itself, is compromised.
Okay, I totally get measuring the nerve directly with electrodes and a tape measure. That makes complete mechanical sense to me.
Sure.
But the medical sleuthing doesn't stop there, because there is a massive panel of blood tests ordered. And I have to push back a bit here.
Okay, push back.
If my foot is tingling or burning, why is the doctor ordering a liver function test? Or checking my vitamin B6 levels? Like, what does that have to do with my foot?
That's a great question. It's because the diagnostic goal isn't just measuring the symptom, it's hunting down the systemic root cause.
Oh, the why.
Right. The nerve conduction study tells you where the damage is located, but the blood tests tell you why the environment became toxic in the first place.
I see.
For instance, they check glucose and A1C levels to look for diabetes, which we know is the primary driver of polyneuropathy.
Right, the busting pipes.
Exactly. And they check serum levels for vitamin B1, vitamin B6, and vitamin B12.
Wait, meaning a nutritional deficit can actually destroy the myelin sheath?
Absolutely. A lack of essential B vitamins can literally starve the nerves, preventing them from maintaining their cellular structure.
That is wild.
Yeah. They also run thyroid function tests and check liver and kidney function. Think about what the liver and kidneys do.
They filter waste.
Right. If your liver or kidneys are failing, metabolic toxins build up in the bloodstream. And those circulating toxins can directly assault and degrade peripheral nerves.
So they are looking for broad metabolic failures.
Yes. And as an absolute last resort, they might perform a nerve biopsy, physically slicing out a tiny piece of the nerve to examine under a microscope.
But that is rarely performed, right? Because taking a piece of the nerve inherently causes permanent damage to that specific fragment. You basically have to destroy it to study it.
Precisely, which is why the non-invasive electrical and blood tests are so exhaustive. We want to avoid the biopsy if at all possible.
Makes sense. So the sleuthing points to peripheral neuropathy. We know the cause, we know the location. How do we actually handle it?
Here's where it gets really interesting.
Yeah, because the first line of defense isn't actually a magic pill. It's this comprehensive, holistic approach heavily focused on nursing care, lifestyle modifications, and alternative therapies.
The nursing assessment here is incredibly rigorous, and it has to be.
What does that look like?
It begins with a detailed history, tracking exactly when the sensory impairments began, and aggressively noting any comorbidities, other intersecting diseases the patient has.
Like the diabetes or kidney issues?
Right. They perform intense physical assessments, including evaluating the cranial nerves and running through highly specific sensory and motor function tests.
And from that assessment, the nurses develop specific diagnoses and goals. The potential nursing diagnoses listed in the presentation paint a really stark, clear picture of the patient's daily struggle.
They really do.
Like, there's risk for injury because they literally cannot feel their own feet.
Yeah.
There is ineffective peripheral tissue perfusion because of the severe blood flow issues.
Yeah.
And, predictably but importantly, pain and anxiety.
The goals are directly tied to mitigating those specific vulnerabilities.
Right.
The primary goal is that the client will remain free from injury. Second, that they report effective pain management. And third, that they can verbalize their feelings and concerns regarding their sensory loss.
The psychological toll.
Yes, we cannot overstate the psychological toll this takes. Losing your fundamental sense of touch or existing with a chronic, invisible burning pain that no one else can see, it breeds intense isolation and anxiety.
I can only imagine.
Addressing that emotional reality is a core structural part of the care plan.
And that leads directly to the non-pharmacological therapies.
Right.
The treatment plan highlights things like managing the underlying cause, physical and occupational therapy, smoking cessation, limiting alcohol, maintaining an optimal weight, and regular exercise.
All super important.
They also emphasize daily foot care, but I have to be honest.
Yeah.
If a patient is experiencing burning pain or pain from a light touch, telling them to eat a balanced diet and check their feet sounds a bit underwhelming.
I get that.
Like, how does checking your feet actually help acute, searing nerve pain?
It is a vital distinction to make, and honestly, a common source of frustration for patients.
I bet.
Those lifestyle modifications, the diet, the exercise, quitting smoking, they are rarely about providing immediate relief for the acute pain happening right now.
Okay.
They are about aggressively halting the progression of the disease. If you don't tightly control the blood sugar, if you don't stop smoking, which, by the way, immediately constricts blood vessels and further chokes off oxygen, the neuropathy will irreversibly spread and worsen.
That's about protecting the baseline.
Exactly. And the daily foot care is literally a matter of life and limb.
Life and limb.
Yeah. It is to prevent a numb foot from developing a small blister from, say, a tight shoe. because the patient can't feel the blister, right? So they keep walking on it.
Oh, no.
It becomes an open wound, gets infected, turns into a necrotic ulcer, and can very quickly lead to a full amputation. The holistic care is preventative armor.
Wow. Okay. That puts checking your feet in a totally different light.
It's critical.
What about the complementary therapies designed to actually manage the symptoms? The treatment plan lists massage, acupuncture, and TTS.
So acupuncture, which is the strategic insertion of very fine needles into specific points, can help modulate how pain pathways fire.
Okay.
But 10NS is particularly fascinating from a physiological standpoint. 10NS stands for transcutaneous electrical nerve stimulation.
Transcutaneous meaning through the skin.
Right.
The visual for this is pretty recognizable. It shows a patient with small adhesive pads placed on their neck and back.
Yeah, you've probably seen them.
Those pads are connected by wires to a small battery-operated device that delivers tiny electrical pulses directly into the skin. But wait, how does buzzing my neck or back stop my foot or arm from hurting?
It relies on something called the gate control theory of pain.
Gate control theory.
Yeah, think of your spinal cord as a literal gatekeeper for signals traveling up to the brain. Pain signals, like the burning from a damaged nerve, travel on relatively slow-moving nerve fibers.
Okay.
10NS sends a fast, non-painful, buzzing electrical stimulus into the same general area. Because the buzzing signal travels faster, it reaches the spinal cord first and essentially overwhelms the gatekeeper.
Oh, wow.
The gate literally closes to the slower-moving pain signals, preventing them from ever reaching the brain. You replace the feeling of pain with a feeling of mild vibration.
That is incredible. You are essentially hacking the spinal cord's bandwidth.
That's a great way to put it.
And before we get to medications, there is one surgical intervention mentioned. It's specifically for peripheral neuropathies caused by physical compression, like nerve tumors or carpal tunnel syndrome.
Right, carpal tunnel is very common.
Carpal tunnel is when the median nerve is literally squished under the transverse carpal ligament in the wrist. Surgery just goes in and cuts that ligament to give the nerve room to breathe, right?
Exactly. When the issue is purely mechanical, like a physical structure crushing the nerve wire, a mechanical solution like a surgical release is often the most appropriate and highly effective intervention.
But what happens when the pain is just too much? You know, when lifestyle changes halt the progression, but the baseline pain is unbearable.
Yeah, that happens a lot.
When acupuncture and tennis units aren't enough to close the gate, and it's not a simple mechanical compression you can just snip away, that brings us to the complex, intense, and surprisingly mysterious world of pharmacological treatment.
It does. And the first most crucial thing to understand is that there is no catch-all magic drug to treat nerve pain.
It's not like taking ibuprofen for a headache.
Not at all. Neuropathic pain is notoriously stubbornly difficult to manage. The medical team will often have to use a layered combination of approaches.
Like what?
They might use topical agents, like a lidocaine patch, to literally numb a localized area of the skin. They use standard over-the-counter pain relievers. Interestingly, they also frequently use antidepressants.
Wait, antidepressants for foot pain, how does that work?
I know it seems counterintuitive, but certain classes of antidepressants alter the specific neurotransmitters in the spinal cord that are responsible for modulating pain signals.
Oh, really?
Yeah. By tweaking those chemicals, they are surprisingly effective for nerve pain, completely independent of their intended effect on depression or mood.
That's fascinating.
But the true heavy hitters for peripheral neuropathy are often anticonvulsants heavy-duty drugs originally designed to prevent epileptic seizures.
Which brings us to the absolute star of the pharmacology section in this presentation. Gabapentin,
Ah, yes, gabapentin.
often known by its brand name Neurontin. This drug is wild. Its therapeutic outcome is listed as decreasing seizure activity and calming overactive nerves.
Right.
It has a massive list of uses. It's used as an adjunct treatment for partial seizures in adults and kids over 3. It's used for ALS, primary restless leg syndrome, post-therapeutic neuralgia.
Which is that horrific nerve pain that lingers after a shingles infection.
Oof, yeah. And of course, general neuropathic pain.
It is a widely utilized, deeply relied upon medication, but what makes gabapentin so fascinating isn't just what it does, but the bizarre, almost ghost-like journey it takes through the human body.
The pharmacodynamics and pharmacokinetics. Wait, let's unpack this together, learner, because reading through these drug specs is staggering. We prescribe patients this heavy-duty central nervous system altering drug.
You're very heavy-duty.
It has intense, terrifying potential side effects like Stevens-Johnson syndrome, which is a severe blistering skin reaction, and rhabdomyolysis, which is literally muscle tissue breaking down and flooding the bloodstream.
Serious stuff.
Yet, when you look at how it actually works, it passes straight through the body into the urine, completely unchanged.
Untouched.
Meaning the body's metabolism does absolutely nothing to it.
Yeah.
It doesn't even bind to GABA receptors, despite having a chemical structure incredibly similar to the GABA neurotransmitter.
Yep.
And medical science literally says the mechanism of action is unknown.
Unknown.
I mean, it's like kicking a malfunctioning TV to fix the static on the screen and just shrugging your shoulders when it actually works.
It is a striking, humbling reality of modern pharmacology. We know that it works to powerfully calm overactive nerves, but the precise biochemical how remains incredibly elusive.
That is just so wild to me.
The current best understanding is that it binds to specific sites in the neocortex and hippocampus, likely involving voltage-gated calcium channels, which somehow structurally stabilizes the chaotic electrical activity of the nerve. But as the clinical data clearly states, mechanism unknown. And you are right to highlight its bizarre transit through the body, the absorption and distribution rates, also heavily variable and practically unknown.
And because its metabolism is listed as none, meaning the liver doesn't process or break it down at all, it relies entirely on the kidneys to filter it straight out of the blood and excrete it completely unchanged in the urine.
Which is exactly why renal disease and hemodialysis are listed as major critical precautions.
Because if the kidneys aren't working,
Right. If a patient's kidneys aren't working perfectly to filter the blood, this drug will build up to highly toxic levels very quickly because the liver can't help clear it out.
let's talk about the timing of that transit. It has a relatively short half-life of 5 to 7 hours. If you take the immediate release version, it hits its peak concentration in your system in about 2 hours. But there are extended release versions, right? Like Grelise or Horizont.
Yeah, depending on the specific extended release formulation, it can take 5 to 7 hours or up to a full 8 hours for a brand like Release to hit its peak effect.
That's quite a window.
It is, and this requires meticulous, careful scheduling by the nursing staff. The goal is to ensure the patient maintains a consistent, steady level of pain control without experiencing severe peaks of toxicity or valleys of agonizing breakthrough pain.
And while trying to balance those peaks and valleys, they have to monitor for a truly massive list of adverse effects.
It's a long list.
We mentioned the extreme ones like rhabdomyolysis and Stevens-Johnson syndrome, but the list affects nearly every single system in the entire body.
It really does.
Central nervous system effects include profound drowsiness, confusion, dizziness, fatigue, anxiety, and paradoxically, it can cause hostility, aggression, and suicidal ideation.
It heavily impacts the cardiovascular system too, potentially causing vasodilatation, peripheral edema, which is fluid swelling in the limbs, and unpredictable, dangerous swings between hypotension and hypertension.
The ENT section, eyes, ears, nose, and throat lists, blurred vision, dry mouth, nystagmus, which is a rapid involuntary eye movement, and Bilharzi even otitis media, or middle ear infections, specifically in children aged 3 to 12.
And the gastrointestinal effects include intense constipation, weight gain, and increased appetite. Respiratory effects range from rhinitis and pharyngitis to chronic coughing.
Wow.
It is a medication that demands profound respect and intense clinical monitoring. We are using a blunt, powerful tool to aggressively suppress the nervous system's electrical activity, and that suppression clearly does not happen in a vacuum. It reverberates through the whole body.
It really puts this whole deep dive into perspective.
I think so, yeah.
We started by looking at the microscopic breakdown of the myelin sheath,
Hmm.
the rubber insulation slowly wearing off the copper wire. We saw how doctors use engineering principles, tape measures, and electrical shocks to map exactly where that damage is, and how nurses use deeply holistic care to manage the physical and psychological fallout.
A full team effort.
And finally, we looked at how, when all else fails, we introduce powerful, largely mysterious compounds like gabapentin to force the nervous system to finally quiet down.
It really highlights a crucial takeaway for you, learner. Understanding peripheral neuropathy isn't just about memorizing a textbook list of medical terms or diagnostic criteria.
No, definitely not.
It is about deeply appreciating the incredibly delicate, complex infrastructure that allows you to simply exist in the physical world. Your everyday ability to feel the solid ground beneath your feet or gauge the temperature of the air or just hold a cup of coffee is an ongoing, fragile miracle of biology.
It really is a miracle.
And it requires an immense, multidisciplinary amount of work to protect it when it begins to fail.
It really does make you appreciate a quiet, comfortable room without any static on the line.
It absolutely does. And if we connect this all back to the bigger picture, it leaves us with a lingering, almost philosophical question based directly on the clinical data we've reviewed today.
Oh, what's that?
Well, if a simple biological glitch, a degraded microscopic sheath on a single nerve wire, can cause the human brain to misinterpret something as gentle as a light touch as an agonizing burning fire,
Hmm.
how much of your everyday physical reality is just a fragile interpretation by your nervous system waiting to be completely altered by a single misfiring cell?